Start out here. Good morning, good afternoon, hello everyone. I'm Nancy Noonan. I'm the clinical specialist for bone marrow transplant here at Children's Oakland, and the presentation today is about CAR T cells and cytokine release syndrome, which is related to a new therapy that's being offered to some of the oncology patients. And the way it's being offered here at Children's is either collaboratively in a study called PLAT2, or it's also commercially available, but it's quite an expensive therapy. So at least initially, most of our patients will be seen in study. And it's a collaborative event or approach between the oncology program here at Children's and the BMT program in collaboration with the people who are running the study called PLAT2 at Seattle Children's. So it's nice, it's a collaborative approach to things. And the BMT, there's a physician lead, Anu Agrawal, but then the support system all turns out to be BMT folks just because it worked out that way. So I'm going to go ahead and get started. So we're going to talk today about, one is we're going to define what a chimeric antigen cell or a CAR actually is. We're going to discuss signs and symptoms of adverse events, specifically cytokine release syndrome. And then we're going to discuss anticipated actions in the event of CRS or cytokine release syndrome when a patient shows up in the emergency department. So we're going to begin with a short video that I found on YouTube. Now, I'm not usually keen on just downloading stuff from YouTube, but this was actually produced by the Oncology Nursing Society, which is an elaborate and quite sophisticated nursing organization, and they put this up on YouTube, and it gives us a 4-minute and 53-second overview as to what CAR T cell therapy is, and it's much better than I could do in 4 minutes and 53 seconds. So the address of the YouTube video is also in your handouts if you have them with you. So again, obviously, feel free to go back and look at it, but it's a really nice little condensed version of what a lot of I don't have to talk about today, but kind of to help set the stage for what I am going to talk about today. Sorry for my big head.
Short for Chimeric Antigen Receptor T-cell therapy. CAR T therapy is breathing new life into the fight against cancer. But that doesn't mean it's perfect. Side effects can come on suddenly and strongly. And when they do, failure to recognize the signs or react appropriately could prove fatal. As nurses, it's our responsibility to know not just what the side effects are, but also how to assess, identify, and treat them. But first, what is CAR T therapy? Some specific tumor cells have the tendency to overexpress certain antigens. CAR T therapy lets us exploit these antigens and use them to attack cancer. The two most prominent examples of this, acute lymphoblastic leukemia and chronic lymphocytic leukemia, happen to cross-express the same antigen, CD19. By combining chimeric antigen receptors, CARs, with specific cancer-targeting antibodies, in this case, those for the CD19 antigen, we're able to create a targeting system. In just a few steps, the system can make the patient's own T cells more effective at finding and destroying cancerous cells. The process for creating CAR T cells begins with leukapheresis, the filtration and isolation of T cells from a patient's blood. These T cells from the patient are taken directly to the lab, where they're placed into a culture and grown alongside the chimeric antigen receptors they're being trained to recognize. Once the CARs have genetically modified the budding T cells, they are reinfused into the patient in a process very much like a typical blood transfusion. As they re-enter the patient's bloodstream, the new and improved CAR T cells leap into action. These genetically modified T cells can now search for and destroy the antigen they were trained to exploit. The hope is that CAR T therapy renders cancer cells unable to evade detection, and these patients will experience full remission long-term. However, there may be toxic responses to this treatment that can arise quickly during and after infusion of the CAR T cells. This is where nurses are especially vital. From the moment of reinfusion, your patient will need to be closely monitored. Labs, scans, biopsies, the works. Most importantly, you must stay alert for signs of cytokine release syndrome, or CRS. This is the most severe side effect of CAR T therapy. CRS often begins with a high fever and drop in blood pressure, but can quickly result into any number of life-threatening conditions such as pulmonary edema, coagulopathy, and even multi-organ system failure. If you think your patient may be developing CRS, don't wait. Get your patient examined. Hospitalization, even intensive care monitoring may be required. Nursing care requires frequent vital sign assessment and laboratory tests, and observation for signs of organ toxicity and failure. If, despite supportive care, your patient's condition continues to worsen, it may be time to intervene pharmacologically. But be careful. The medications used to treat CRS could inactivate the CAR T therapy. As such, you should cross this bridge only as a last resort. But when you do, know your options: tocilizumab and corticosteroids. Tocilizumab is a monoclonal antibody that binds to the IL-6 receptor to prevent inflammation. It's fast-acting and clinically indicated in cases of severe hypotension and rapidly deteriorating organ function. Corticosteroids, on the other hand, act directly on the patient's T cells, blocking further activation. As you'd expect, this makes steroids an even riskier option, as they may be more likely to inactivate the reinfused T cells. To summarize, while CAR T therapy has already proven itself incredibly valuable in the fight against leukemia, it still carries a high degree of risk. And remember, in the event of cytokine release syndrome, early intervention and vigilant assessment could mean the difference between life and death. To learn more, visit ons.org, where you'll find more educational content like this and resources curated exclusively for nurses like yourself.
Okay. So that was a quick overview, but were you able to follow along with it?
A little bit, it's still looking.
Yeah, it's not exactly what one would call ED friendly to start with, just because of the content. So I try to use that just to set the stage. So let's take a little bit of a step back. I'll give you a little bit of basics about the immune system, and again, to enhance your ability to understand what we're doing. And then on the back side, why this requires really rapid intervention. So what we're doing essentially is manipulating the immune system. And you'll recall, or maybe learning for the first time since nursing school, that the primary role of the immune system is to identify self from non-self. So for me, it's what's Nancy and what's not Nancy. My immune system is activated every time it's exposed to something that's not Nancy. That could be abnormal cells, like cruising for malignancies. It could be exposure to bacteria, fungus, viruses, protozoas, foreign tissues, like that liver transplant that somebody wanted to give me, let's say, or even just some kind of foreign protein in the form of a medication or maybe a food substance if there's something that your body is not going to respond to well. So this is a pretty busy slide, but the big picture of all of this is that you have a non-specific and a specific immune response, and there's communications amongst all these different kinds of cells, like T cells and B cells, leukocytes, mast cells, all the cells that promote identification and communication, and they all secrete substances called cytokines, which on a very simple level basically say, yo, over here, come on, come along with me, we have an infection, we need to recruit everyone that's available to eliminate that organism, whether it be virus, fungus, foreign tissue, an intended transplant, just whatever it happens to be. So by the time you get down to this level, you have lots of secreted substances like interleukins, IL-2, IL-6. These are famous for causing inflammation. So to get from here to here, this is a whole process of wicked inflammation. So can you think of another disease or another entity when inflammation plays a huge role that somebody might end up in the emergency department for?
Sepsis.
Sepsis, perfect. Anaphylaxis, right, bingo, that was really good. That was what I was looking for, although sepsis is a really good answer. CRS is kind of like cytokine release syndrome. It's kind of like an anaphylactic reaction. So you can see these are the kinds of things that need immediate and very pointed intervention. But we have to treat it differently, and we'll talk about why. So the other thing that you might hear about, again, related to this whole discussion about CRS, cytokine release syndrome, or CAR T therapy, is that these cells are globally referred to as immune effector cells, IECs, meaning that they're cells that can be differentiated into a form capable of modulating or affecting a specific immune response. So all of these kinds of products, they take the basic function of a T cell or a B cell, are then manipulated to then do a very specific job. Like T cells, their main role is to identify, within the system, to identify that abnormal I don't belong cell and then communicate with other cells. But in the CAR T example, we take T cells, transfer genetic material into them to make them identify one very specific type of cell called the CD19, which is a B cell leukemia cell, and they just go after that full bore. That's all they want to do in life is attack CD19 cells. And what I mean by CD is on the outside rim of these cells, I always think about it like they display little golf flags that say, hi, I'm CD19, or hi, I'm CD4. So it's a way to identify under the microscope and by staining and looking at genetic material of what kind of specific kind of cell it is. So B cell leukemias are often CD19 cells. So again, the CAR T cell therapy will be directed at CD19. You can direct a CAR or a CAR T cell therapy at any kind of, theoretically, any kind of cell you want, but what this therapy does is direct them at CD19. Now, if we were currently at City of Hope or another place, they might be directed, the CAR cells might be directed at a type of brain tumor, let's say. So they're doing that. Again, if you watch 60 Minutes.
How do they teach the CAR cells to go after the brain tumor cell as opposed to the such and such cell or the such and such cell?
So what they do is they, there's gene transfer involved. So they transfer genetic material that through antigen and through antigenetic communication that redirects their ability to go after a cell. So they transfer that material into the cell that says, you're going to look for this very specific type of receptor.
So they take the patient's blood, they do electrophoresis, they separate out their T cells.
Exactly.
And then they're going to, somehow they're going to infuse the T cells with some information of the specific, the specific cell that they want to target and destroy.
Yes.
But how do they get that information into the T cell?
Oh, it's
Fancy gene therapy.
It's gene therapy. So there's
Okay.
a way that you use a virus and you package.
Because viruses go inside the cell.
Right, so you use the virus and you package the material that like I know how to do this,
Yeah.
these are the bench people. You package that specific instruction with genetic material into the virus. The virus dumps its gut into that cell.
I see.
The cell integrates it into the DNA and they become instructed from that point forward, we want T cell, we
So,
want CD19.
How does it? This is just maybe this isn't too in depth, but suppose when you have these City of Hope brain cell, City of Hope, the brain cells, how do they get? Do they like go in, extract some of the brain cell from the patient, and so they can figure out the genetic material?
Oh, figure out what the marker is?
Yeah, marker.
So often you can actually figure that out from a biopsy.
Oh, okay.
But I don't know a lot about CAR for brain tumors, so that's
Okay.
my assumption. I can't
Okay.
speak to that.
Right.
Leukemia, it's a little bit easier. You draw off their cells and you know
Right.
what the target is.
Okay.
The brain cell piece, I would let the brain cell people talk about, but in theory, it's the same kind of approach.
Okay.
I'm sorry, I don't know that.
No, it's all right. I'm following along. Go look.
Oh, good. Well, that's good. That's half the battle. So a chimeric antigen receptor, and this may talk, so there's this formal definition, which is an artificial receptor that combines with an antigen specificity domain coupled with an intracellular signaling domain typically expressed by an immune effector cell, like a T cell or a natural killer cell. So basically, in English, you're modifying a cell, specifically a T cell, by adding a new receptor against a very specific antigen combined with a T cell, which is capable of seeking out and destroying any cell that displays the chosen antigen. So formal and then kind of little kid English. And in this situation, what we're doing is we're using T cells to develop a bad bomb for B cells. specifically CD19 B cells. So in order to be eligible for this specific type of CAR T therapy, you need to have B cell positive leukemia. In other situations, it might be a
B-cells were
brain.
part of the immune system.
Pardon me?
Aren't B cells part
They
of the
sure
immune
are.
system?
They sure are. But
So-
they can develop leukemia. They can go awry, just like everything else.
So the
But they're different than a B
B-cells are-
cell. Different
in
entity.
this type of leukemia, the B cell becomes part of the problem.
Yes,
Okay.
exactly. So you can have a leukemia that's B cell derived or T cell derived,
Gotcha.
or myeloid, which is a whole nother topic for a different day. Does that help? Great. Okay, so here we have a schematic representation. We have a T cell. It's added in that CAR, that chimeric antigen receptor that's going to go get those bad cells. You put it in the Petri dish, the bench people do their stuff, gene transfer takes place, and you end up a cell with a very specific antigen receptor on its surface to go after and seek out those badly behaving CD19 cells. So again, the point of this slide, just another example, a photo example of talking about when you activate the immune system, you have bad inflammation. So in the sense of activating the immune system with CAR Ts, that's good because it activates those cells and it calls other CAR Ts and develops additional cells to attack that badly behaving CD19.
If it goes awry, that's where
Yeah.
the problem.
Yeah. But that inflammation is good, but it also can become part of the whole issue that causes patients to get sick in the hospital or end up in the emergency department with that overwhelming inflammation called cytokine release syndrome. We're going to just skip this one because it's inflammation, so we don't need to talk about that again. So what kind of patients might you see in the ED based on the plan of action here at Children's? So as I said earlier, the oncology and BMT services are anticipating commercial product use or clinical trial use. Chimeric, which is also known as Leclusil, was approved in August 30th, 2017, a product by Novartis. It was approved by the FDA for use in patients less than 25 years of age with B-cell leukemia, not T-cell leukemia, B-cell leukemia, which is also known as ALL, that is refractory or in second or later relapse. So you have to be not in a good place with your disease to be eligible for this therapy. As most therapies, when they're first released by the FDA, you have to be in a place where you're pretty high risk. Some people would refer to this as salvage therapy, which is a term I try not to use, but it really implies what we're after. And then where we're going to see most of our patients here is through clinical trials, working in a collaborative situation with Seattle Children's, and it's called PLAT2. I mentioned earlier, City of Hope has a trial for glioblastoma, which is a type of brain tumor, and lymphoma. CHOP, where a large percentage of the work was done for pediatric B-cell ALL. These are the folks that really got this started, and it was it was probably 15 years ago, at least 15 years ago.
Is Chimeric, are they more generalized CAR T cells?
No, this is a CAR T. Chimeric is a CAR T, FDA approved for use in CD19 leukemias.
Okay. So it doesn't have to, it doesn't always have to be developed specifically for that patient if we know that that patient has.
Right. It becomes an issue of you having the type of leukemia that this CAR T is directed at.
Okay, so if
So this is a
like two
huge.
people have the same type of leukemia, they could take this CAR T cells, the same CAR T cells, theoretically. Okay.
Exactly. Because you're looking for that, you want that CAR T to be reactive to CD19.
Gotcha.
It's not reactive against CD22, which is another type of B-cell leukemia. So if you have B-cell or CD22, this therapy, you're not going to be eligible and it's not going to work.
What's the difference between like transfusing out the T cells in our patients and turning them into CAR T and putting them back in versus like this pre-made drug that already has a ready and
well, there's different ways that you can do the gene transfer, and the products are different in small ways, which are probably not pertinent to what we talk about here. But there's some individualization, which is why there's been FDA approval of other products for CAR T cell therapy since this point in time. All about genetic and a method of seeking out the identified and eradicating the identified cell.
Question. So will every patient that gets this therapy have their blood drawn, electrophoresis, T cells isolated, and then they mix them with the Chimeric?
Right.
Is that where am I going?
Yeah.
Okay.
On study, the patients won't get Chimeric. Patients that are on study, they'll have their cells currently sent to Seattle, where they do a gene transfer with a different type of CAR T product.
Okay.
So there's one that's FDA approved, and then there's one in study, and there's multiple different kinds of CAR products available to turn a T cell into a CAR T cell.
Okay.
Does that make sense?
Yes.
Okay.
All right.
This is hard to explain, and I apologize if
No,
it's
no,
really
it's just
interesting.
it's the way it is.
And it's really non-ED-ish, this is like really kind of in this whole other space for you guys. So what kind of patients are going to be eligible for this therapy? So we're going to see patients that inducing malignancy remission in patients with refractory disease to initial therapy. So these are the patients that get their induction therapy, and they're still way positive with disease. So they have really bad response to their induction therapy, or they have what we call refractory disease. We've thrown a lot of therapy at them, and they still remain with their malignancies. Consolidating patients with persistent minimal residual disease or malignancy, consolidating is throwing a chunk of additional therapy at them to get them to the next place where they need to be, which would most likely be a bridge to stem cell transplant. So let's get them in a place where we can induce some kind of relief of their malignancy in enough time to identify and prepare a donor for them to go to stem cell transplant. So this may end up being that kind of waiting therapy, buying more time, or if a patient doesn't have a donor, this may be, CAR T may be the identified therapy. And then, of course, within discussion about this, it's like, well, do we really need transplant anymore? Is everybody going to respond? Now, this is a relatively new therapy, so we don't know. These are some indications and questions that are yet to be answered. So we'll see as time goes on. Some centers are proposing CAR T after stem cell transplant, and in the initial stages at CHOP, we had a patient who we transplanted here, and he relapsed probably about a year, had CD19 positive leukemia, relapsed about a year post-transplant, went to CHOP, got his therapy, and he's been disease-free for 4 years now. So we have, what's really nice is we have local evidence that this therapy works. Every time we see this young man in clinic, we know that it works, so it's lovely.
Is it a one-time infusion?
So right now it's a one-time infusion, but there might be indications in the future. It may develop into, there might be something that you offer multiple times. Depends why you would relapse, which is a pretty complicated discussion. But right now it looks like it's going to be a one-time. Right now.
Okay.
I don't say never because,
Right.
I'm not good at the bench, so I don't know what else they're cooking at the bench.
How many are you planning to enroll?
So we've done one so far, and we have the second patient who's been collected, and her T cells are cooking in their little Petri dish up in Seattle right now.
Okay.
So let's talk a little bit again about the overphoresis. How do they come? The overview for CAR T. How do they come to us? You identify patient who has relapsed or refractory B-cell malignancy, CD19. They go through an inclusion criteria for the study, make sure that they can participate in the study. They go to leukapheresis, which is over to the apheresis center in the day hospital. They have a mononuclear cell collection. Currently, then that product goes to Seattle in their bench work. They have a retroviral transduction with a anti-CD19 CAR. So you're creating that CAR T by mixing the CAR with the anti-CD19 information in the T cells. And then the patient comes back in, gets some preconditioning chemo that lymphodepletes them. So they get therapy that's really lymphodepleting. So they'll get some therapy not quite like they were having a stem cell transplant, but enough again to drop their counts down, and then they'll get their CAR T infusion.
What will they use? Those drugs that suppress that. What drugs do they use?
I think the young man might have gotten fludarabine and something else. So they're chemotherapy drugs. We're not throwing the entire huge myeloablating forever trying to get rid of your stem cells type of high dose chemotherapy.
And for the preconditioning chemotherapy,
Mhm.
is there a certain one that you're using each time, or is there a bunch that you can pick from?
There are a number that you can pick from. They give you a choice to pick from, and then you also want to look and see what the patient had in the past and if they've responded or not responded to that. So there's a bit of a cocktail that you can pick from the chemotherapy. Again, you want to find something that's historically active against ALL, but I think one of them is fludarabine, and I apologize, I can't remember the other one.
So is there a time period of how after they get this reinfusion of these anti-CD19 CAR T cells, how are they predicting that their chemotherapy afterwards, the time would be less, they may not need it? I mean, what kind of parameters are you looking
that's
at?
where we're going next. That's where we're going next. So anticipated side effects, monitoring, and event. So we'll talk about that in this section. So the focus of this talk is really to talk about cytokine release syndrome. What is it? Why is it such difficulty? And why does it happen? So what I really need to emphasize, and this was a shift for the inpatient staff, is we know that cytokine release and neurologic toxicities are expected. When you infuse an immune effector cell, you are just begging or taunting the immune system to have a big reaction, right? That makes sense. So this is really important. So patients will experience cytokine release syndrome and possibly neurologic toxicities. They can experience these often with anywhere from day 2 to 22 post-infusion. Now in Seattle, these patients they get their lymphodepleting chemotherapy, and then within about a week after that, they get their CAR T infusion, and then they go home. And we're like, oh, you gotta be kidding me. But they have a 24-hour outpatient center, or it's close to 24-hour outpatient center. They have a very sophisticated outpatient service from seeing stem cell transplant recipients for, decades. Our program is not that large here, and we clearly don't have the resources to have that kind of outpatient support. So by virtue of that, we're keeping our patients in until we see them demonstrate some CRS, or they're beyond that really high risk period. And that's what's happening with our patient who received CAR T on July 2nd. So he's actually going to be discharged hopefully this afternoon, or if not tomorrow morning. So there's that window of day 2 to 22 when they're at high risk for therapy, but that doesn't mean that they can't go home and never have another event with CRS if for some reason that their immune system gets really stimulated. It's possible that they could have another CRS event, which is why the primary reason why I'm here today and we're taping this, to give you information about cytokine release syndrome and what to expect when it cruises through the door. So again, cytokine release syndrome is expected. And so cytokine release is a non-antigen specific toxicity that occurs as a result of high-level immune activation. So again, if you have all these T cells floating around, they all get activated, you're going to see a lot of inflammation and you're going to see a cytokine storm. Think about when you have the flu. What do you feel like when you have like influenza, right? The old-fashioned viral flu. You're hot, you're fatigued. Somebody looks at you cross-eyed and it hurts. You have high fevers. Sometimes you get a little wacky. You're not sure about how you feel or about where you're at. So these are the kinds of things that you'll see with CRS. So it's a constellation of reactions secondary to release of all of those cytokines. So similar, sometimes when you have the flu, you don't feel bad because you have a virus. You feel badly because of your immune system trying to eradicate the virus. It's all that cytokine, everything's swollen and boggy. So again, it's also a constellation of symptoms that occur when T cells engage and begin to proliferate in the body, leading to a head-to-toe inflammatory response.
So some inflammation is good, and the CRS is when it's like
Exactly.
Okay.
So you want these T cells, after you infuse them, you want them to take hold and proliferate. And if there's any microscopic or invisible disease, you want them to go after those cells. But what you don't want is a head-to-toe cytokine storm where you become hypotensive, neurologically toxic, fever, cardiovascular so-called. You don't want all of that. But people haven't figured out how to modulate that yet. Like a low dose of T cells or a high dose people haven't figured that out yet. So what you need to do is be prepared to treat, monitor, and then treat if patients end up developing cytokine release syndrome. And what we found since all of these pediatric patients are being treated, that we're finding similarities. Like you may see a fever right away, 12 to 24 hours later you might see neurologic toxicity, and then they're figuring out when to intervene based on treating large numbers of patients. So we're getting better at collectively the group is getting better. Now that I've been involved in one, I can say we. Collectively we're getting better at this. But there's still that unpredictability because you're talking about the immune system. You don't know whether it's going to go off full bore or if it's going to just be quiet. So in some of for the Chimeric, for the FDA, the approval trials, CRS, there were 3 trials here. CRS was present in at least close to 80% of all the patients. So I show this slide, and again, specifically with the inpatient staff, we expect this. And in this situation, close to half saw an ICU admission, about a little over a third got an anti-cytokine therapy. So this tells us a lot. This tells us that we need to monitor these patients. They're at high risk for an ICU admission, and we're going to have to use cytokines.
Have you found that the cytokine release is time limited? Like if they're in the ICU and they're hypotensive, can they put them on like a vasopressor for a certain amount of time to support the blood pressure?
Yeah, so the patients respond really well to the supportive therapy, but what you need to do is people have expired related to CRS. So you need to provide good supportive care, but at some point in time you also need to provide this anti-CAR T or this anti-CRS therapy. And
but you don't want to do that, right? Because that essentially...
Yeah, exactly.
You're
like, well, you guys are way ahead of the mark here. That's exactly it. I'm getting there. We'll talk about that because...
then it just negates everything you've done.
Exactly.
Okay.
That's exactly... So it's this.
Where do you draw the line?
Come see, come sa, however you want to say it. It's a little... You have weight. So this talks about CRS and then relapsing, remitting ALL. CRS typically occurred day 1 to 22 after infusion. And so that's when we made the decision to keep these patients inpatient, because with the traffic in the Bay Area, and then our lack of sophisticated outpatient services round the clock, these patients aren't going to get this at 10 a.m. in the morning. You know that. They're going to get this at 11 o'clock at night or 3 a.m. just because that's the way the world works. And we don't have our outpatient services at that point in time are the emergency department, which are great at emergencies, but none of the other standard outpatient therapy options are available. So this is why we decided to keep them in. But there's still concern that at some point they may have another event of CRS once they go home, once they've been treated.
And our
So
patients travel so far for
Yeah,
oncology
exactly.
treatment.
So some of these patients are going to be required to stay local. So what we're trying to do here is hedge our bet. Educate people, educate the family, educate the people, wait till there's a lower risk time to send them home, and then we feel like we have our bases covered. So what does CRS look like? Fever, chills. This looks like sepsis and anaphylaxis, or a wicked case of the flu. Fever and chills, nausea, vomiting, diarrhea, anorexia, hypotension, and this is from capillary leak. They get really boggy. So what happens when you've lost all your vascular tone? You get hypotensive, you get tachycardic. Asthenias, which are abnormal physical weakness or lack of energy. Every class I talk, people ask what that is, so we just put it up on the slide. You have tongue and throat swelling, which is classic anaphylaxis. You can have dyspnea, renal dysfunction related to your hypotension and capillary leak, coagulopathies, and headache and myalgia. So there's this whole constellation of things that can happen. Kind of looks like fever and neutropenia, right? A little bit. All right. So this is another slide, and it's available in your handout. It just talks about the same thing and the presentation. There's some other additional information here that I'm not going to present right now, but we are going to talk about what tends to go hand in hand with CRS is some neurologic dysfunction, and it can be looked at as part of the constellation of CRS or separately, depending upon how you choose to look at it. But patients will present often after they've had some soft signs of CRS, confusion, aphasia, unresponsiveness, and is difficult as seizures. But the key with these patients is they have slight changes in neurologic status or level of consciousness for 12 to 24 hours, and then they kind of fall off the deep end. At least that's what the most recent experiences have been telling us. So for inpatient, this is one of the other reasons we're keeping the patients in. So you need to be exquisitely sensitive while they're inpatient to agitation, delirium, cognitive changes, loss of balance or weakness. So if we give this to a 3-year-old, this is going to be a tough call, right? Because sometimes 3-year-olds are agitated, they act like they're confused sometimes. They have cognitive issues, or they can have loss of balance and weakness just as part of daily life. So again, we bring our pediatric perspective here, but this is one of the big changes that people will see is speaking or comprehension. And one of the things we're doing as an inpatient monitoring is we're taking daily handwriting samples. Every day, the patient can pick any sentence they want. They just have to write the same sentence or a similar sentence day after day after day. And the research team and the clinical team are looking at these on a daily basis to see, do you see any difference in their handwriting, which has been a great way. And people have people that have had patients with bad CRS have seen differences in their handwriting. Also, the other thing that is just the key for this, which I didn't even put on the slide, is headache. Patients who have headaches. So if you have a headache that's responsive to acetaminophen, great. If you have a headache that's responsive, then it comes back, then it's responsive. You're thinking, this might be indicative of toxicity and or CRS. But if you have a headache that's non-responsive, then you're thinking this is a real problem and we've got some toxicity going on here. These other sequelae are usually seen in the inpatient phase, not so much in the emergency department unless they're in full-bore CRS. But again, that's most likely going to happen when we're keeping the patients inpatient earlier on. Now, a year from now, if this therapy is still an event, maybe it'll be different. Maybe they'll get it in an outpatient and go home. I don't know. But anyway, so that's where we'll go. So the keys here, again, are early recognition. So the family's educated before they go home repeatedly. What do they need to call in for? So it's going to be fever, swelling, headache, chills, nausea, vomiting. The same things that they're usually educated about calling in related to fever, neutropenia, or sepsis, right? These are all kind of the same kinds of things. But again, we're going to emphasize who they call. You don't show up in the emergency room unannounced. We really try to get our patients to call in first so that you have some warning that they're coming. Most of them do that, not all of them do that. So we have a lot of family education so they can, the HEMONC or BMT people can screen the calls. And then obviously you're going to have careful assessment for signs and symptoms of CRS. So when patients come in, you might ask them to write something for you. It won't help you based on what they wrote yesterday, but it might be a good baseline. And then early intervention, which means that they're going to be a priority triage assessment in the ED for their treatment and evaluation. So in general, patients who present in ED with a history of CAR-T and current concerns are fever, neuroabnormalities, and or headache require a rapid assessment for sepsis and CRS, similar to that of fever and neutropenia.
Will it be obvious in the chart?
Yeah, and I have an example of that. There'll be a couple places. So my understanding from my discussions, I learned about the emergency department, of which I really know nothing. Other than that's where when you call 911, where people go. That you use a code called Red Team and they go to room 7. So that would be your general expectation, just like your fever neutropenia patients. You want to do vital signs, a brief head-to-toe assessment, neuro assessment from your nursing perspective. And you're going to make sure that it's pediatric sensitive. In other words, you're going to ask the family, I don't know your 12-year-old son. Does he usually babble? Or does he not babble? Or does he when he doesn't feel good? Is this a normal behavior? So you incorporate the family to identify the kid's norms and abnormal behaviors. If they look bad versus good, and I'm sure working in the emergency department, you all have that general ability to say he looks good or he looks bad. If they look bad, then you're going to apply the CR monitor, oxygen monitoring, and move to the recess area, because that means that bad things are probably going to happen. And then the HEMONC BMT should call ahead of time. They should call ahead of time, communicating with your staff to be able to know that the patient's coming in and not arriving unannounced to staff. And then the other just note here is their presenting condition can also mimic anaphylaxis. So the patients are educated to say, 1, we have cancer, we're oncology or a transplant patient. 2, we have a fever, which is emergency. 3, we've had CAR-T cell therapy. So they are told to mention that when they come in. And then if they also, the physician staff can also notify your physician staff to expect that. So you're going to see notification of the ED physician, fever and neutropenia, normal routine blood studies, cultures of each lumen of the CBC. You may also likely see orders for things like ferritin or other immune or inflammatory markers, things that are going to sound really unfamiliar. Maybe CRP, you guys are probably familiar with CRP. Ferritin is a great marker for inflammation. They'll want you to draw ferritin, but there will be specific orders for that. And then medication-wise, you're probably going to start antipyretics, antibiotics. We may consider tocilizumab, which is an anti-IL-6 medication. IL meaning interleukin, which is a cytokine that can cause inflammation. So if and when that might be the medication. I don't think it would probably be done in the emergency department. They would get transferred up to the floor, or if they were that bad where they needed toci right away, most likely they get transferred to the ICU or to the floor.
Is that the one that sort of reverses the
Mhm.
effects of the
Yes.
therapy?
It's an anti-IL-6 medication, yes. And this one is acceptable, and it's really reasonable because it can prevent that escalation to bad CRS. But there's another medication that you don't want to give, and I'll move on to that. In the immediate situation, you're going to consider IV fluids. Obviously, they're hypotensive. They may need vasopressors for hypertension and hypotension. And again, that's okay because that's routine supportive care. But you do not give steroids, dexamethasone, corticosteroids. Absolutely not. Steroids will grossly reverse the CAR T cell ability, the CAR T cell intended therapy.
Even more so than the toci?
Yeah, the tocis is accepted as kind of a temporary, and it's IL-6. Steroids they're anti-IL-2, and that's one of the main fuels for T cells is IL-2 called interleukin-2. So we don't want to give steroids unless it's seriously considered. And in this situation, we want the investigators, the PI or the co-PI. And I put the 4 names here, and again, you're probably not going to be involved in this decision, but what your question would be if somebody orders steroids, your question would be, did anybody talk to the PI or one of the co-PIs before I give this steroid? That would be your question.
So,
Yeah.
I just want to confirm that this docilizumab, how do you pronounce it?
Tocilizumab. Toci.
That will not reverse the.
No, and it's acceptable to give, and we've already given it to one of our patients.
Okay.
Yes. The one that you want to worry about is the steroids.
Okay.
I have a quick question it's definitely a what if
Yes,
question
absolutely.
that may not happen, but so knowing that some of the signs that we will see mimic anaphylaxis, and knowing that, you have a patient that's like, well, I have cancer and I'm getting this therapy, but also I just ate peanuts, and you just don't know.
Yes.
Would it harm this patient if we ended up giving epinephrine in this process of figuring it out?
Epinephrine's fine.
Okay.
Epinephrine's fine. Would you want epinephrine and Benadryl, acetaminophen,
Okay.
any other kind of I shouldn't say any other kind, excuse me. Epi and Benadryl, knock yourself out.
Okay.
Absolutely. But what you don't want to
But
do
no
is give
steroid, no
corticosteroids or dexamethasone.
Okay.
And so excuse me one second, and to be able to prevent that, we've talked about medical alert bracelets, and we've pros and cons, and we decided we're not going to go there because most of the time people ignore them. And these are pediatric patients, so they're always going to have an adult with them, and the adults usually know what's gone on, and they'll know to say they've had CAR T cell therapy, they have cancer. We have put corticosteroids in. This is I know, I apologize, it's really hard to see, but what I did was I took a snippet of this patient's actual allergy list, and corticosteroids are here, and it says, do not use corticosteroids at any time, except in the case of life-threatening emergency, severe cytokine release syndrome. So we're attempting to move that way. Parents have been educated about that as well. And again, if there's some communication with the PIs or the oncology, the entire oncology service and BMT service are familiar with this. So when the ED people call to do a consult or let you know, they're going to readily say, don't give them steroids. Sorry, I put you off.
No. Is the toci medication, is it a one-time dose you give? And the second question is, once you give it, how long does it take to start working?
Great question. So I don't think you'll be giving that in the ED, but it's an infusion over about 2 hours.
Okay.
I don't anticipate, but you never know. If things are bad, you might. There's also a nursing protocol on how to give tocilizumab, administration of tocilizumab, in the BMT section of documents. So that's available to you. And interestingly enough, in the patient, so our patient got toci on, I wrote this down before it came, on day 6 post-infusion, and for unrelenting fever. First he had a fever that was responsive, then it wasn't, then it would take, you'd give him acetaminophen and it would climb back up 6 to 8 hours later. And it progressed over a few days to the point where he had unrelenting fever, so he got a dose, and he had questionable neurotoxicity. So we gave him toci, and and his immune markers were off. They were like, up in the stratosphere. Within 12 hours, after the toci, his fever broke. Between 24 and 48 hours, he was having maybe fevers once or twice a day, and his immune markers were almost normal again. So this toci will act, the literature says, within hours up to 48 hours. So that's what happened with him. He responded really well.
Wow.
Yeah.
But toci is not considered chemotherapy per se.
Toci is not,
No.
it's a monoclonal antibody, so it's not chemotherapy, yes. It's just an
So if need be,
immunosuppressant.
we could give it.
Yeah, actually, yes, very much. You likely could give it. And if you're not sure, you call 5 South and ask for some direction. Yeah.
Interesting.
It's used in the adult rheumatoid community. It's called Actemra. Actemra is the name of it. I think it's primarily an adult drug, like for the rheumatoid population. So again, your supportive care are antipyretics, antibiotics, IV fluids, antiemetics, supplemental oxygen, neuro assessment, and maybe even if they're having inappropriate neurologic toxicity, you may even give anti-seizure meds, and then moving forward, IV fluids or vasopressors. So this patient might make a pit stop with you and may go to the ICU if they don't respond to fluids and they're still hypotensive. They may or may not. I don't anticipate this, but we just don't know for sure. You escalate to Actemra with continuing or worsening symptoms to treat adverse sequelae. It's a monoclonal antibody that targets IL-6, and it counteracts inflammation in CRS, and it can resolve within, I got ahead of myself, it can resolve symptoms within 24 to 48 hours. Methylprednisone is reserved for those where you have incomplete or unresponsive CRS and unresponsive to tocilizumab. And this is clearly going to be a PI decision when this comes about, because it can counteract the activation of T cells, either temporarily or permanently in this situation. So you want this to be a really thoughtful intervention, not something like, I don't like the way the kid looks, he's hypotensive and he needs vasopressors. Well, so be it. Give him fluids and get him vasopressors, and let's ride this out. Give him some toci and let's ride this out. Let's see if we can manage this with standard supportive care and the tocilizumab before you pull the trigger. And the people who make Chimeric have these whole algorithms set up when you're using their product on how you would make this decision. This is what Seattle recommends which was really helpful for their clinical stuff. So fever of greater than 38.3, you give acetaminophen every 4 hours. If you're persistently above 39 for 10 hours that is unresponsive, then you give toci. So that there's a pretty low trigger for toci here. But they also know, because once that continues, if you don't treat the fever, then you usually have 48 to 72 hours before something else is going to start to pop up, and you're going to have progression of the CRS. So again, people have learned over time, based on patient treatment, how to intervene and still preserve that CAR T ability to affect disease, but decrease some of the inflammation. So it goes down to illustrate all of this. And again, that's in the nursing protocol that's available. I don't think they're going to be in the ED long enough for you guys to have to implement this.
If you have an oncology patient that's eligible for this and it goes along well and then they don't do well, so they're taken off and they're given this, this medication, are they allowed later on down the line to try again, or is it like it's a one-shot deal if it didn't work the first
For
time?
right now, on the study, I believe it's a one-time, but I don't know where this is gonna go. As people continue to collect data and are able to implement care and look back and say, these are patients that responded well, these are patients that didn't, how do we need to manipulate their care, or are they eligible for something else, or should we look at this again? That, unfortunately, I don't have the answer to right yet. So if you want if the patient's going to be in the ED for a little bit, where do you find these nursing resources? And right now, all of the transplant-related resources are on, the Novell application launcher. So we have a little icon that's a dog with a bone that says bone marrow. So there's an area that says nursing resources. There's a procedure on how to give CAR T. You won't be doing that, I guarantee you. We're not giving CAR T cell infusions in the ED. But there's one on how to give TOSI, and then under protocols, there's how to care for a patient or what to be alert about when you're caring for a patient who is at high risk for CRS. So those are available. And then physician staff also, we have medical SOPs that are also available. Currently, they're available right now on the dog under IEC, immune effector cell. And then they're also on, all of our transplant-related medical SOPs are on a third-party website.
What's SOP?
Standard operating procedure, sorry. Our medical guidelines or standard operating procedures are on a third-party website because we are required by our accreditation to make sure that there's document control, so people can't print them and carry around and save them in their locker for use 18 months, 12 years, a decade, 2 decades later. So that's why they're not there. But all of this is available on the dog.
So, question, one thing we didn't talk about was coagulopathy. So
Usually
what does that
not
look like?
usually not a presenting symptom. It's usually if they've gone a while with hypotension.
Okay. So it's like
So-
a DIC picture?
Exactly. Not right away.
Okay.
Not right away.
So we won't be given fresh frozen platelets or things
I
like
doubt
that?
it. No, I think the only time that you may see that if a family sits on this at home for days, and they're not going to.
Okay.
Even the families that have a hard time incorporating directions, whatnot, they're not going to sit on this because there's a lot of education that goes into before they get the therapy, how serious this is, salvage nature of the therapy. So these families are pretty motivated.
Do they have a maximum number of people they can enroll, or just whoever?
I don't know. I didn't look. I honestly didn't.
They're currently in the study.
So we have one patient who's
Just one.
infused on July 10th. So he's probably going to go home today. He's recovering his counts from his initial chemotherapy, recovering his counts. He had an episode of CRS, got TOSI, and recovered lovely. And he's starting to recover his counts. And he was having a PET and CT done today for disease restaging. And then within 2 weeks, we'll also have, he had a bone marrow. I think he had a bone marrow this week. So we'll be knowing a little bit more about his therapy. And then right now, there's also a patient who had her stem cells collected a week or 2 weeks ago. I can't remember. And her cells are doing their thing in the Petri dish up in Seattle. So number 2 patients.
How many patients do they have up there? Seattle, since that.
I have no idea. I can't even keep track of my own. I have no idea. This is also really helpful. This is in the medical standard operating procedure, which is an algorithm on how to make the decision, if this, then this, and I know you can't see it here, but trust me, it's an SOP it's a cytokine release syndrome. It's in the medical SOP. It's also in the nursing cytokine release syndrome protocol. So that my belief is that if you understand how the medical team is making decisions, you're going to be even better at making nursing decisions based on your assessments and your plan of care as a nurse when you have some understanding what the medical team is thinking and doing. So this is why this is also included in the nursing protocol available to you.
Another question is, so this syndrome, it looks like it mimics an allergic reaction in many ways?
It does.
So one of the things that, we give H2 blockers.
Those are fine.
And we can give those without any...
Yeah, in fact, some of the recommendations where you give an H2 blocker ahead of time before you actually infuse the drug or treat with an H2 blocker. H2 blockers are fine. It's just the big no is steroids.
Right, okay.
In any form, steroids, whether it be methylpred, dexameth, hydrocort, just ixnay on the steroids. So what are we going to do? How do we look at this outcome measures? Just really quickly. Patients who get therapy, now you have to think about this for a bit, it makes really good sense. They become permanently B cell deficient, right? Because all of their T cells are trying to eliminate their CD19. So most B cells express CD19, not just the ones with leukemia. So this means the patients have no B cell function. So they have an element of lifelong, hopefully, lifelong immunosuppression, which may require them to get routine IVIG infusions, because your B cells are the ones that make IgA, IgM, IgD, IgD that fight infection. So this is good therapy, but it does not come without some kinds of sequelae, even in a good situation. Medication interactions, obviously, no steroids. I'll say that over and over again. We have to report our results to the clinical trial because we're good participants, and we want to, as we contribute, then we learn more. Children build on the backs of others, so that people participating now are going to hopefully affect the care 6 months, a year, or 5 years down the road of care that kids will require it. This is for me. The Transplant program has FACT accreditation, what's called the Foundation for the Accreditation of Cellular Therapy. They now have a whole separate component for IEC therapy. So we have to worry about this, because in order to provide consistent IEC or CAR T-cell therapy, we have to be accredited in order to get reimbursed by CCS Medi-Cal. They put a moratorium on that to start, because I think there's only one center, well, there's actually no centers in California that are FACT accredited for CAR T-cell therapy, but that will come down the future. So when you look at the bigger picture, we have to worry about that.
And reimbursement, what's that in reference to? It's a clinical trial.
Reimbursement, right. So clinical trial is not a problem. We still need to get authorization, because the clinical trial does not cover the cost of all the therapy. It covers the cost of the drug. So we need still reimbursement. CCS needs to authorize this. However, if you were to get the medication just through your insurance company, if they approve, it's some of the estimates have been as low as $300,000, and some are upwards of $500,000. So you have to have good insurance to be able to get this drug, good private insurance. So as we move forward, what kind of challenges? The production of CAR T cells is difficult. Throwing the genetic material and the virus and the CAR T cells in that little Petri dish, however they do it, doesn't ensure that you get good gene transfer and have a good product outcome. Right now, when the products come, they come with a certificate analysis that tells us they have a minimum cell count and their the sterility is negative. They've been handled by a majority of people, so we need to make sure our product didn't pick up any kind of organisms along the way. Handling challenges. CAR Ts, there's a risk of cross-contamination in the lab, and they're very sensitive. They need to be stored at like minus 150 degrees Celsius. They need to be transported that way. You need to know what you're doing when you handle these kinds of cells. There's challenges with cancers. There's escape. What happens if your cancer is CD19 positive and CD22 positive? Are you going to have escape and recurrence from those CD22 cells? We don't know. That's a possibility, and it has happened. And then we also need to take into account, for this, making this drug is really expensive, all the R&D. Is it going to drop price, or is it going to continue to climb as they further build on this? There's a lot of, there's a lot of unknowns way beyond how to treat CRS. But I would be remiss if I didn't mention any of those, because that's part of any new therapy.
That's part of the political aspect of R&D. I mean, look what happened with the EpiPens.
Yeah, here you go.
Maybe
Yeah.
that one.
So one final question. Which one is the leukemia cells and which one is the T cell?
T-cell's a yellow one.
T cell's the yellow one. That's why I love T cells. They are so ballsy. They'll go after anybody and anything. I love T cells. So that's it. Thanks for your attention. I really appreciate it.
Thank you. That was a really good class. Enjoyed it very much.
Thank you.
You're welcome. Any other questions?